let's wrap up this session, and I ask you all to get out your crystal ball for IO therapy and forecast where we're heading with this. And Nayar's kind of already alluded to this. Are we okay accepting that immunotherapy may be given up front to all patients, irrespective of a biomarker, and maybe concentrating on the science and the refractory setting for biomarkers? Or are we more inclined to continue to search for better biomarkers up front? Where is this going? Haas?
Look, I think the paradigm that we've been operating on, you look at the NCI, look at ASCO, look at all the guidelines. What is it that we always emphasize? Personalize your delivery of care. Heterogeneous disease. You want to be able to identify the right patient for the right treatment. And this hodgepodge of doing everything up front just because we have a couple of data is something that's not going to be effective for most of our patients. We want to deliver care to the appropriate person so that if there are toxicities, it's justified. So if there are responses, patients could really benefit from it. So going back to what Nayar was suggesting, high TMB, high PD-L1, the data right now says use IO. Remember that in this country, we have data that up to 30% of non-small cell lung cancer patients never make it to second line. Older data set, platinum doublet only, I understand. But nonetheless, we have that in the back of our head. So you want to give the appropriate care up front. So if the paradigm right now says PD-L1 and TMB is what we have to choose, then that's what we use, and we offer IO up front. And then for the ones with the lower expression, maybe a combination with chemo. For the ones that have no expression, maybe chemo alone until we learn. But your comment that we need the science behind it is absolutely right. And I think that's the part that's lagging, and that's the part that always lags and gets us into these kinds of binds that we are right now. So the science has to progress a little bit more fast.
And I think there's clearly need for further refinement of biomarkers. We've talked a lot about exciting efficacy in these patients. What we haven't talked much about is the minority of unfortunate patients who end up with significant toxicities, and that can be crippling for some patients. So there is an ugly side to immune checkpoint inhibition, and that should prompt all of us to go to the drawing board and continue to look for markers so we precisely select patients who should get these therapies.
Roel, your thoughts on this? You've been intimately involved in a lot of the research efforts. Are we need better refinement? You're okay with the upfront select group of patients?
Well, we're starting at such a higher level than we had before, so it really is amazing, and it's good news for patients. That said, there's no doubt that we have to personalize this, as we've heard, and it's not going to be effective in everyone frontline. Studies are now being done on exceptional responders, those 4, 5, 6-year patients. What is it about them? Many others might need other things. They might need combinations, either combinations of immunotherapy. I wouldn't have thought it, but I think the chemotherapy does have a role, and the anti-angiogenic. So it's really going to be understanding the patient's tumor and their immune system. So both, and then personalizing that care. And think of it, we spent 15, 20 years figuring out how to do this for targeted therapy. We're only in the infancy of immunotherapy, so we shouldn't think that it would work in everyone. But I bet by the time we're doing this 5 years from now, we'll know who should get immunotherapy up front, who should get a combination, or who maybe should not get it till the later stages of their disease.